Welcome everybody. Dulcet tones into the microphone. Can everyone hear all right? Excellent, thank you for nodding. That's very helpful feedback. Welcome to our first WHA side meeting on skin disease. I'd like to introduce, to kick off and welcome us, the President-elect of the International League of Dermatological Societies, Professor Henry Lim.
Thank you very much, Claire. On behalf of ILDS, I'd like to welcome all of you to participate and to engage in the inaugural meeting of this skin NTD. And I'd like to specifically thank Dr. Sose, who had come here as the head of the NTD program. I know he's very, very busy, and it's really appreciate he is taking the time to participate and engage with us, and also the entire team who has been very, very engaged with our organization. I'd like also to thank our co-host and co-sponsor, Inigo, who has been in charge of Anesvad Foundation, and it is truly a great partner for us to be able to work together and the entire team to be here. Also, I'd like to thank our own Claire, who has been very, very involved in this entire program, and all the staff, Arpita, as well as Liz, who has been helping along with all of you to organize this program. So with that, I'd like to again sincerely welcome all of you and to express the support and the enthusiastic engagement of the ILDS in this program. Clearly, we will continue to move on and in partnering with all of you. I'll turn this over again back to Claire.
Thank you very much, Henry. So could I have the first slide, please? Thanks very much, Liz. So I'm Dr. Claire Fuller. I'm chair of the International Foundation for Dermatology. I'm a dermatologist by day in the UK and by night anywhere that I need to be. I'm also on the board of the International League of Dermatological Societies, and on behalf of the ILDS, together with the Anesvad Foundation, really delighted to add my welcome to this WHA side meeting. We in the Skin NTD meeting community are truly heartened by this interest shown in this event, and look forward to a really action-oriented discussion over the next hour. We've the right people in the room to make an impact, with experts from diverse backgrounds and leaders from different disciplines and different sectors of the health delivery space. Next slide, please. We were keen to convene this gathering following a highly successful first of its kind Skin NTD meeting in March of this year, appreciating that skin disease frequently is disabling and stigmatizing and causes immense suffering and adverse impact on mental health and well-being. This meeting gathered leaders in neglected disease, but also neglected tropical disease, but also skin disease, with over 300 people attending in person and more than 1,000 virtually, representing some 86 countries, many of which are endemic for neglected tropical diseases. We were graciously hosted by the WHO NTD department, and Dr. Sose called for investment in this often neglected area, all of us appreciating that skin is the key access point to achieve universal health coverage. Thanks. Integrating NTD actions, and thank you, Priya, for this fantastic word cloud, and interventions around the skin, we note that there are more than 15 out of 20 of the diseases in this group have significant skin manifestations, and it's now well established in our expert community as a key step to achieving WHO NTD 2030 roadmap targets, as well as universal health coverage. So integrating is absolutely crucial. Next slide. And our conclusions were, from this highly motivating and productive meeting, were endorsed and supported at the highest level. Why should we be hosting this meeting? Well, the ILDS, whose mission is skin health for the world, and do have your photo taken with one of our placards before you go. We have access to more than 200,000 dermatologists across 98 countries. And the Anesvad Foundation focuses on projects and actions and interventions to address and resolve skin NTDs. And together we're passionate and motivated to maintain the momentum emerging from this March meeting. Next slide, thank you. So we want to enthuse you over the next hour to join us in these actions, focusing on ensuring skin diseases are prioritised with universal health coverage, building capacity of community health workers to deal with common skin diseases and thus identify NTDs early and manage and direct them appropriately, increase the influence and number of dermatologists within health policy planning, strengthen surveillance and integrate reporting of skin diseases, particularly skin NTDs, to ensure the true burden and robust data is available to inform accurate and targeted NTD master plan developments by endemic countries. Next slide. So I'm now honoured to invite Dr. Sose, head of the WHO NTD team, to set the scene from his perspective. Thank you, Sose.
Thank you, Claire. Good afternoon, dear colleagues, friends, and partners. It's a great pleasure for me to join you today for this important side event during the 76th World Health Assembly. As you know, the theme for the 75th World Health Assembly was Saving Lives, Driving Health for All. And let me express my sincere gratitude to the Anesvad Foundation and to the International League of Dermatological Societies, both in official relationship with WHO, for organizing this important event. And I was really impressed by the skin NTDs meeting last March, not only because of the number of participants, over 1,000 you just mentioned, but also because of the quality of intervention and technical input. And I believe this has created a momentum we need really to maintain and use to move to concrete actions. I keep saying that for NTDs, we need to move from advocacy for the sake of advocating to advocacy to actions. Everything should lead to action right now if you want to really position the NTDs within the global health architecture. So this is a critical momentum and we shouldn't let it go. Let's continue working together. I know we are already, stepping in the next step, putting different working groups and to make sure that we can continue having concrete action, and this is really excellent. And the outcome of the meeting clearly stated that we need action-oriented, way of dealing with NTDs for early detection, early diagnostic, and appropriate treatment, including at the primary health care and frontline level. And I believe that it will be part of the discussion because the priority areas we just presented include capacity building for frontline workers, making sure that they have the right tools to do the work. And so NTD roadmap and the skin NTD framework are our guiding documents, and I encourage countries and partners to implement them so that we can progress towards the target set. So thank you for your ongoing commitment to NTDs and skin NTDs in general, and let's make sure that we all push together to accelerate the implementation of all this framework. Thank you.
Okay. I don't need a microphone. Yes, you do. I do. Great. Thank you. Okay. So good afternoon, and thank you for coming to this side event, and especially thank you for state members for your interest in skin NTDs. So Anesvad Foundation is a Spanish foundation based in the north of Spain with only one purpose, that is to fight skin NTDs in sub-Saharan Africa. Actually related to the ODS number 3.3, that is to end with NTDs. So our work, we support local civil society, research centers, and government. That's our main focus. That is support the national programs in order to be able to work in their master plan that is related to the WHO roadmap. And we do it by an integrated approach. So I'm going to explain during the next 5 minutes our experience supporting this government, these Ministries of Health, these national programs in this work on the integrated approach. Next one, please. Okay, so these 4 countries where we have been supporting them are Ghana, Ivory Coast, where we work in 15 different districts in Ghana and 6 in Ivory Coast. Next one, please. And Togo and Benin, where we work countrywide. Okay, so we support these national programs and the Ministries of Health, as I mentioned, with 9 different work packages. It means like a group of activities. So these work packages are social mobilization, active case detection, diagnostic, treatment, physical rehabilitation. These 5 are the cycle of the disease. So we consider them as essential to be worked and to be supported with the national programs. The social mobilization is, we talk about prevention, we talk about community approach. Meanwhile, the other 4 are more vertical towards the patient. Always prevention is the first main step, because as soon as we are aware of our health problem, we are 1 step closer to the universal health coverage. The active case detection is another really very relevant work package where we have been supporting community level activities, door to door, and also tracing close contacts, especially for leprosy. Plus, working with diagnostic, treatment, and physical rehabilitation, and as I mentioned. Next one. So, but for us, there are 2 other pillars, 2 other work packages that are especially mentioned as main pillars also in the WHO roadmap, that are very important to be tackled at the same time as we have community activities. That is the country ownership and the mainstreaming. So country ownership, in our opinion, is very important, so the countries are less dependent on outside, on external actors. And because as we see, this is an important topic to work related to the country ownership. Mainstreaming is another very big challenge, because the countries, they need to have policy coherence between the national level, the regional level, and the district level, plus also good coordination between different ministries. So these are the 7 work packages that we support, and at the same time we consider also that some social determinants of health are very, very relevant to be worked. Especially in our case, it was depending on the context, but in our case was WASH and gender. But in some areas we were tackling also environment or other issues related to migration. Okay, next please. So the next one, please. Okay, so we did an analysis, different evaluations of these 5 years of intervention in these countries. I'm not going to go through all this data, but if you are interested to see all the different impacts and results of this intervention in these 4 countries, we analyze the impact of all the different work packages. And what I'm going to do now is to tell you what, in our opinion, are the main lesson learned after these years of working together with the national programs. Next, please. Next one. Okay. Okay. So the first one is again about prevention, about social mobilization, because we saw that it wasn't working as we expected, and we weren't improving the level of passive detection. That means the people going themselves to the health center instead of us or the national programs going to the community to work on active case detection. So probably we need to improve these work packages by probably getting involved in this type of activities to the traditional healers or teachers that at the moment they are not so involved, and still the first choice is always the traditional healer instead of going to the health center. No, so in the social mobilization there are still a lot of things to improve in all the countries where we were supporting. Next one, please. So, as I mentioned before, also mainstreaming is a very important issue to have this policy coherence, and we saw that we are sometimes very good building strategic plans, but we have weakness making them operational. So the relation between the district level, that it has to be the base of a pyramid, is not the coordination is strong enough with the regional level and strong enough with the national level. Sometimes we put too much effort in the national level, and the district level it should be more empowered or more in coordination with other levels. So we believe that we should work on this, not so much with the strategic papers like the master plan, that are of course are very important, but how we make them operational, involving also other ministries that are very relevant to tackle some of the social determinants that I mentioned before. Next one, please. This is what I was trying to say now. I mean, there are very relevant issues that has to be worked at an horizontal level, not so much at a vertical level that some of the other ones I was mentioning before, like diagnostic, treatment. And of course, this is a matter also of prioritize them, because the needs are very big. But the good thing is that all these social determinants of health are useful for any type of health issue. So it would be always relevant to put them into practice together with the integrated approach on a skin NTD. Next one, please. This is also a very relevant lesson learned that we had again in the 4 countries, where when we were doing aftercare detention, when we were supporting the national programs to do this activity, as you see the figures, these figures are from Benin, from 2017 to 2019, and as you can see, most of the skin diseases that we detect are not NTD skin diseases, are other dermatological issues. And closer. Okay. Like that? That's fine? Oh, okay, sorry. Like that. Okay, thank you. Okay, so as I was mentioning, this was a very big issue for us, because most of the cases, as I mentioned before, that we were, that the national programs were detecting were skin diseases, but only from 3 to 5% in all the countries, in the 4 countries, were skin NTDs. And by the way, most of them were scabies. So this opened lots of different questions, as I mentioned in the slide. Like we have to think about how do we deal with this? No, I mean, do we need more training in the dermatological issues? Of course, more resources to carry out this training. We are providing by free the medicines for biliary ulcer, for example, but not for other dermatoses. And this is something very difficult to understand for the population when you treat some of them and not other ones. So this is a big thing that we have to, and as I mentioned, is common not only in these 4 countries. We were in Holland just a few weeks ago, seeing another research related to the integrated approach, and we saw the same thing in the other countries. No, like so, if you do the integrated approach, normally you are gonna detect lots of skin diseases. So this all brings us to a main challenge, and one of the reasons, or the main reason why we are here. No, so how can we help to further strengthen the health system so we can successfully attend a wider range of community health needs? I'm not talking just about skin NTDs. I'm talking about the rest of the health difficulties that any district have. No? The importance of starting with a very strong primary health care system together to go for the universal health coverage. So this, I think it summarizes everything that we found out during these years of intervention in the integrated approach. Thank you.
Thanks very much, Sose. So thank you very much indeed, Inigo. That was really good scene setting. And we wave bye-bye to Sose, who's heading off to another meeting. So we move now into a time of discussion, roundtable discussion. And what we'd love you to do, if you'd like to respond to any of the points that we bring up or have any questions at all, that you say your name and which organisation, where you're from, just for orientation and also for our video. And the reason for recording this is to share with those participants who haven't been able to attend but had registered, and also for our own purposes to really consolidate the actions that come out of today. So I hope that's all right with everyone. Obviously, we need a lesson in speaking into the microphone. It seems that you want them on tilt like this, speaking in like pop stars. Like we're just... Okay. And so we're all heading for Eurovision Song Contest. Yeah, so we can do a little bit of that later. So thank you for that. And we'll keep an eye on little comments, waving of hand coming from over there. So thank you. So perhaps we could have the first question up, Liz, with a couple of questions. So these were circulated to the member states who are participating, and thank you to those of you who have come from there, but not all of you will have seen these. So perhaps we could think about universal health coverage, the right-hand side here, as being discussed at a high level at the United Nations General Assembly this year. How do we support the efforts to ensure that dermatological support and skin NTDs particularly receive necessary attention and resources at the global level? I would have thought that's the million-dollar question, but I just wonder if anyone has any thoughts about how we might approach that. I'm just wanting the WHO NTD department to feel ready to respond when I direct the question. Daniel, I just wondered if you'd had any thoughts about that particular question. And if we can get the mic to him. I love it when you're on the spot. You just always answer so beautifully, so I'm waiting for...
Okay, thank you, Claire. You put me on the spot. So, yeah, okay. I think the pathway for inclusion of whether it is skin health or other global health initiative, when it is driven by WHO or initiated by WHO, is first to have this initiative accepted by the respective regional offices and by the respective member states. National program managers are part of the member states. So gaining the acceptance, not only the acceptance, also involving them from the conception and all of the development process of the initiative is the most important thing. So then there are these formal WHO pathways that we normally use. This could be, depending on the level of the issue, this could be regional or global resolutions, which are done by globally by the WHO or regionally by the regional respective committees. If it is not, that level of initiative, then we in the program also help in developing regional strategic frameworks to help guide national program managers to adapt or adopt as it is. So depending on regions, sometimes there is this intermediary level regional document adaptation to specify it to region level, but sometimes countries directly take also the global strategic framework documents to develop national action plans or operational plans in order to integrate and mainstream this. So then there will be other products like guidelines, strategic documents, manuals, SOPs, or standard operating procedures depending on the program. So this is more or less the way, and also there will be a number of consultative processes that involve member states, like review meetings, developmental meetings with including all partners to develop. So WHO for this purpose also uses technical advisory groups to guide its decision. So this is, I think, in short, the pathway that we use.
Thank you very much. So are we having a lock-in until we've come up with a resolution? Before we're not leaving until we've developed a resolution. No, that may be a bit ambitious, but thank you. One of the things I wonder if I could touch back to you, Inigo. You mentioned the first port of call in the primary healthcare setting or the community setting continued to be the traditional health worker. I know in our March meeting that there has been direct work with influencing and working with traditional healers to assist them in aligning their approaches with perceived reasonable practice. I just wondered if you had any comment on that, or whether any of our participants have any thoughts about how we can successfully work with or enhance, or perhaps refer to successful liaison projects with traditional healers in this context.
Well, I only can say that you have to involve them from the very beginning. So they have to feel that you trust them. But like everywhere, I mean, there are good traditional healers and not so good traditional healers. So like any leader in any community. So you have to understand how these things work out, no? But from the very beginning, they have to feel that they are part of the whole process. If not, you start with the wrong foot.
Is Sol still here? Oh, yes, a question.
Hi everyone, my name is Frida Dunger. I come from IFBA, the Global Patient Organization in Psoriatic Disease. And I'm Swedish actually, so we won the Eurovision Song Contest. But two things to say. In psoriatic disease, in psoriasis, we have a resolution and we have a global report on psoriasis. And that's 10 years since that was launched next year. But that isn't really enough. So even though we have that, we all the time have to collaborate. And I think that's really a key point. And also try to put psoriasis in other agendas. So for example, last year we talked about mental health. And then we can see what is WHO doing about mental health and raising awareness here. So really attach the cause to other already existing agendas. I see that as very helpful. And also to comment on what was said before, to really include the people living with the disease in the decision making and in all this process from the beginning. That's very helpful. So how we do from the global office is, we can do global agendas and we can set the tone or show the direction, but we really need to work regionally and locally to really distribute this and work together. Maybe Kathleen want to share something.
I'm so glad you picked that up, because we were absolutely intending to direct that first question to you. So thank you for volunteering without me even having to do that. Okay, good. So that is really, really, really key, that we involve the patients or persons affected. And I think in psoriasis, you've been really successful at that. It's a challenge in the NTD department. I just wondered if you had any advice for us on how we effectively involve the patient voice.
Yes, so one thing is to see if there is a national patient organization. That is a really good idea because they normally have the connection out to the people living with the disease. Then you don't have to talk to as many people, or the patient organization can organize different meetings for you. That is most effective way. And if you don't have that contact to a local organization, then you can always contact the global one and we can help supporting finding there. And of course, there is other than IFPA in other disease areas.
Thank you. And it is a big challenge with NTDs and skin disease in general because there's so many diagnoses and they're common disorders that tend not to have patient organizations. So we need to think of a surrogate way perhaps.
Yes,
and I completely understand.
I think also
psoriasis.
But if there is a good dermatology and you have that contact, the dermatologist can also be helpful in finding that strong advocate. So in a meeting with a patient, seeing that as a leader, if you find a good leader, we can always, as a global patient organization, train that person in becoming more than an advocate and maybe even start a patient organization or gathering a group. In some countries, it's not even possible to start a patient organization. That type of format doesn't exist. But then just a Facebook group gathering to share knowledge and just because living with a skin disease can be very lonely and you have stigma and discrimination. So just being together with others is also very helpful.
And the other thing we've been reminded is that the patients are voters, whereas we tend to be cost centres. So for the minister's point of view, having the patient voice is really helpful because they're more likely to contribute to subsequent elections. Perhaps we could move on to the next question. Please feel free to put your hand up if anyone's got any comments to add or just yes.
So thank you for this opportunity. Maybe before we go to the next question, I just wanted to share some insights on.
Can you just say, I didn't catch your name, sorry.
I had not yet introduced myself. I was just asking that I be allowed to share.
Of course you can. You can say whatever you like.
On the first question, I'm Dr. Sultani Matendechero. I'm the Deputy Director General for Health in Kenya. But previously, I was the NTD Program Manager for Kenya. And one of the things that I wanted to share that one of the experiences I had with the NTDs in general, not just skin NTDs, is that these being diseases of poverty, they are forgotten. And so the first problem is that all the stakeholders do not really appreciate the magnitude of these diseases, to the community and even to the society in general. So what we need to really focus on is, first of all, to get even the community members themselves to be aware that this is a problem, to understand. Because when you move in those communities, sometimes they have resigned to accepting these as, eventualities of witchcraft and things like that. So these are not diseases to them. These are just ways of life. They've been bewitched and so on. So one of the things we need to really think about as a global community within that context is, how do we involve the community? A very good entry point, and I was speaking to the issue around the whole conversation around UHC. Many countries are now embracing the primary health care approach, where we are activating the community health strategy. And in Kenya, for example, now we are really building capacity so that we have very many community health promoters, about 100,000. So that for every 100 households, we have a community health promoter. That becomes a very good entry point to create awareness, even in the community itself. Now, once we have that kind of awareness and the community members appreciate that these are diseases and they even have names and they can be treated, then we start utilizing the available resources, because for entities, usually the resources are very scarce. So we now start utilizing the scarce resources to build up a database. And then we can be able to reach out now with evidence, data, which can be able to help us package our evidence to the policymakers and even the people with the resources so that they can be able to see the magnitude of the problem, and slowly by slowly we can start unlocking the resources. That is probably one of the things that we need to think about as a global community, even as we think of unlocking, because I can see there we want to receive necessary attention and resources. So with regard to resources, we have to showcase the numbers, the disease burden, but we have to start by creating awareness even at the community level. Thank you.
We are so lucky that you have had the journey you've had into the Ministry of Health. That's fantastic. So you're going to be my target now, so just watch out. We've got your email address. So I'm just thinking, so we were being tasked by SOSE to think of actions that are concrete and achievable. And in order to create the data so that we have a real understanding of burden to be able to go and convince resource allocation, we need that data. So how do we collect? And so one of the things that came up a lot during the March meeting was the technique of the big skin camps, where they're effectively big integrated skin surveys on large proportions of the population, screening 2,000 or 3,000 people, and you'll pick up a range of neglected tropical diseases, but you'll also pick up a range of other diseases where the unifying thing is they're coming to have their skin checked. And I wonder whether that is a potential resolution, that we make a recommendation that happens as the basic screening for the number of skin NTDs that exist in an endemic country. And I'm absolutely happy to be super challenged on that, but it's just a potential action. And the other thing that you were talking about, I guess, is, the community, I love the word, what was it? It was community health promoter. It sounded similar to the health extension worker model used in Ethiopia. And I'm just wondering what didn't work for your social mobilization that you didn't find helpful. So maybe it was a different technique that was used.
We probably need, as you were mentioning, to involve more the people-affected organizations. There are not so many actually where we were working, but they are starting. They are starting to be organized, and actually they are pretty good for monitoring and evaluation activities. What is basic to have evidences, because everything related to monitoring and evaluation sometimes is more about culture. The people are more accustomed to implement activities. Even the organizations, we want to implement things, we want to do things. But it's something cultural, no? We need to start focusing in the evidences, because with evidences later we can enlarge wherever intervention in any country. No? And social mobilization is the same. We need to really very well understand what's not working, to understand who should be involved, or if the tool that we are using for social mobilization should be changed. I mean, there is much more need in evidences, even related to these prevention issues, not only about treatment or diagnostic.
Thank you very much. Liz, can we have the next question thing? So this is sort of leading on to this. What might be the most effective activities to promote for inclusion in UHC? If we're calling to be included in UHC, what are the most effective activities? And I guess it may, we've touched on some of them, but any thoughts about what concrete activities we might be asking to have included?
I think listening to his presentation, he made mention of some lessons learned in those countries that they operated. And I saw something like inclusion in wellness, because most skin conditions, if the person does not present, there's no disfigurement, the person will not come. But if we create some sort of wellness in the form of going to communities to screen, and then you add screening skin conditions to it, it will bring out the number of people with these skin conditions. And you also need to, when you detect this, you should link them to treatment. Because in our country, in fact, I didn't introduce myself, from Ghana, I'm a technical coordination director at the Ministry of Health. I mean, the cost of treating skin disease is very expensive. So you go to community screen, and then the person cannot afford a treatment. It becomes a bit unethical. So whatever we are doing, we should do it within the context of some of the treatable conditions that maybe you detect and treat. And the chronic ones that we can't treat, we also need to maybe educate the patient that this one has protracted course of treatment, and you need to understand the cause. Otherwise, people have that stigma. The traditional rule, healers that you talk about, they are the first point of contact. And they will go there, apply their help because it's very cheap at the community level. But when they come to the orthodox space, very expensive. And we also need to look at diagnosis. So what my brother said, we need to look at the whole care continuum. And then we will include it in the UAC package. As a nation, Ghana, we are trying to update our UAC package. And the lesson that I've learned at this meeting, sure when I go home, we will try to update whatever we have so that the skin conditions will be uplifted into that program. But what I'm trying to say is we must begin to look more into wellness clinics to detect these conditions early and manage them. Thank you very much.
So that's really helpful to trigger me into my elevator pitch now for dermatology, which is 1/3 of the world's population have skin disease at any one time. The top 8 conditions, there are top 8 conditions that will account for 80% of the diagnoses. The majority of those are very cheap to treat and make a massive impact on someone's quality of life. The problem of not treating is extremely expensive because it's debilitating and stigmatizing, and patients fail to contribute to the economy. And I think these are the arguments that we probably need to say more, so that they're right at your fingertips when you're going to argue for resources for us on our behalf. So we need to get our elevator pitch even slicker, I think, for that. But the economics is really important. Have we got any health economists in the? We were nabbing your colleague, but she's not here. Okay, wonderful. Yes.
Yeah, my name is Jan Thilo Klimisch. I work with CBM, Christian Blind Mission, based or having its main office in Germany. I'm heading our Berlin office, and we are quite engaged in NTD works for quite some decades now. Also founded a network in Germany with different stakeholders, science, pharmaceutical companies, politicians, and of course civil society, trying to raise more awareness on the fight against NTDs. One more aspect I would like to add, and many very important aspects have been already mentioned, as the strengthening of community-based approaches, as stepping on the aspect that with the UHC high-level meeting in New York, there are lots of discussions going around with reprioritization of primary health care. I think we should also I'm a bit upset until now that when I regard now what has happened until now, we had that G7 leaders communique mentioning NTDs, yes. Also at the multi-stakeholder hearings on the high-level meetings in New York on UHC, skin NTDs have been mentioned. Too briefly, in my opinion. So I think we should rather have a broader argument on the role of NTDs, and also the role of NTDs regarding the monitoring, the accountability. So I think they are perfect indicators for reaching those furthest behind, the most marginalized, and perhaps also arguing with that aspect around the high-level declaration declaration. So this zero draft on the high-level declaration just came out now 2 days ago, I think, and I think that's now the opportunity for all stakeholders in the field of NTDs to try to put in some more arguments on NTDs in the text. Thanks.
Thank you very much. Henry?
So just want to add a comment that about the inclusion to policies. Obviously, in the U.S., we don't have universal health coverage, but we do have a lot of experience in getting diseases covered by insurance company, because unless it is covered, patients would not be able to access the medication. And the most powerful aspect is indeed, what had been mentioned before, to advocate to the decision makers. A lot of times these are the Congress people, the senators, and so on and so forth, with patient group. Usually once a year, for example, our academy has what we call a day on Capitol Hill to advocate for certain issues. Some of them is access to medication, and we target it on certain diseases that is very common, with very strong patient advocacy group to go there, because they are voters, so they are listened to. They're more than they are listened to more effectively than listening to physicians only. So I think that had been very, very powerful. And I would agree with my colleague in Sweden that for those patients group that may not be formed yet, dermatology definitely can form it. In our own hospital, we formed a vitiligo support group. For example, we have a lot of vitiligo patients. They don't have an organization. We formed that. So it is something that can be done organically with some organization.
And of course, we had Global Skin, which is the international patient organization for all dermatological disorders, at the meeting in March. And obviously, but they're very aware of those difficulties where there isn't a patient support group, and this community will struggle with that. But it is a really, really good point. We just got to think smart about how we do that. Yeah.
Hi, I'm Kathleen Gallant. I'm also with the International Federation of Psoriasis Association, working along with Frida and ILDS and Professor Lim. But building on what you said, Professor, the chairman of my board of the International Psoriasis is a dermatologist from Kenya. And about 15 years ago, he's seeing so many psoriasis patients that need help. He took it upon himself with his colleagues in the hospital to form a group. He formed the National Psoriasis Organization in Kenya, based in Nairobi. And from him bringing his patients to meet each other, true leaders rose up from those patients that wanted to change the situation in country. And therefore, they joined the international group, which is my group, and then went on to advocate at the national level, the international level, and ultimately here to WHO, where we indeed got our resolution on psoriasis 9 years ago. So I think a lot of the professionals in this room working in country can bring your patients together socially, because when you have a skin disease, especially a communicable disease, which psoriasis is looked at, you don't want anybody else to know you have it. But you're dying to actually have somebody understand you, know one person. If the doctors, the community-based health workers can bring these patients together to meet each other, and then they can all join together and change the situation. And I love what I'm hearing in the room, and I completely support you. And so whatever advice or knowledge that we can help our friends at ILDS with you moving this agenda forward, we're really happy to do it.
That's fantastic to hear, and thank you very much, Catherine. I wonder if we could have another question. I think, Jose, this has got your name on it. So can digital technologies and innovations be leveraged? Well, Jose and we've also got another expert here, Christoph, is in the room. So I'm sure you'll have something to say to this. Perhaps, Jose, I could ask you to speak to this.
Thank you, Claire. I'm Jose Antonio Ruiz Postigo, medical officer and WHO Geneva Skin NTDs team. I've been reflecting on what have been said, and rather than answering this question, I have more questions, no? Because I fully agree with Dr. Sultani and our colleague from Ghana when it comes to if we don't have data, to whom we are going to talk about. But now the challenges that we have first to have all skin NTDs and all NTDs in the Global Health Observatory of WHO. That is one challenge that we have. And the data of WHO comes from the countries. So here comes again the ball towards our colleagues in the ministry. How feasible you think, regardless of the technology that we can use nowadays, is to have those diseases reported with very few indicators? The second is, I think we have reached a moment where for skin diseases, it doesn't help only the number of cases, because this stigma, this impact in the life of people. And I think in our department, we are mainly focusing on number of cases, the parasite, the microbe, but I think there is still room for improvement to document the impact in the psychological or social aspect. And then another question is, if non-skin NTDs are 95 or 98% of the skin diseases that matter in the community, how are we going to work with Ministries of Health to have a database that captures what Inigo showed, that is the tinea, the abscesses? So it's very difficult, no, for the health information systems to accommodate new indicators. So I think here we have a true challenge, because we all recognize data is important, but to get that data, it has proven a real challenge. So to finish my intervention is, I think digital health technologies are there, mobile phones, apps to convey training, to capture data, but we need systems in place, and then to make sure that we agree between partners, Ministries of Health and WHO, how we are going to do that. My plea would be that, can we have a champion in the room, a country where we can pilot that the data that Inigo showed in his slide is not from his slide. It comes from the ministry, it comes through WHO, even if it is from a champion country in the room or those who are attending remotely. Thank you.
Thank you for that challenge. Christoph, do you want to say anything? Yeah.
So, excuse me if the comment is a bit more, it's a bit more specifically about the technology. I think that when we have data, we have, I've been working for an initiative, there's a side event this afternoon, it's called the IDER, which is the Digital Health Initiative and the use of AI to assist in these technologies to develop solutions. So what I believe is that there are two types of data. There's one which is called sensitive clinical data, and that is making a diagnosis. And then there's what we call non-sensitive data. And that can be a content about when you actually make a diagnosis. And when you have this content, of diagnosis which is already made, you can actually work on that content to create different ways of generating. I guess we all know what that means today. We can generate responses which are adapted to specific levels of a healthcare provider or a patient, or we can adapt the content very easily nowadays. So that was just a general comment.
Thank you very much indeed. So one of the, Liz, yes.
I just wanted to mention, as we're talking about surveillance, one of the things that the ILDS has been doing in partnership with Global Skin is funding the development of a new tool to measure the impact of skin disease on patients, and it's a patient-led initiative, a patient-led measurement called the PRID. I think it stands for, I have a note, the patient-reported impact of dermatological diseases. And so the hope is, and it's being rolled out, it's a survey this year, but that will give us more insight into the actual, the burden of these diseases, that we just really aren't able to capture thus far, and I think that will help give us that foundation to really show why these diseases need to be prioritized. So it's an exciting development.
And I think following on from that, you know, the sort of the question of how do we get the data? Patients know if they've got something wrong with their skin, and what happened in the Côte d'Ivoire study was patients came forward with skin disease. They were then screened by the community healthcare worker, and those that the community healthcare worker didn't know what was to do then came through to the next group, and it went from a community of around 15,000 down to 2,000 being examined. So there is the mechanism that needs refining a bit, but that is something that we could think about how to develop a methodology or a standard operating procedure. I think it's coming.
Along that line, also, I think, you know, the teledermatology or telehealth definitely can be used once you reach the community health worker. If that technology is available, if you can train the community health worker to properly, for example, document or video the skin lesions that can be forwarded to dermatologists. Likewise, you know, and this is done already, that biopsies can be done as teledermatology, right? You can take a biopsy on one site and it can be referred to someplace else to have it read, and that can be done very easily if technology is available.
I mean, certainly technology is going to leapfrog lots of activities, and we look forward to Christoph and his achieving that. We're approaching just 5 minutes to go. Maybe we'll just take one more question and then just wrap up once we've done that. So if we go on to, thank you, equitable access. This is a bit of a biggie. So what measures can be taken to ensure equitable access to affordable and quality treatments, medications and healthcare for individuals affected by skin disease, taking into account particular barriers for women, children and people with disabilities? I guess we've been covering some of that, haven't we, really, actually? Liz, has anyone got any final comments before we... Yes, Priya.
I speak from my experience back in my home country, Nepal. I'm Priya Pathak. I work for the Skin NTDs team at WHO Geneva. From experience from Nepal, I see that a lot of burden is over the shoulders of female community health workers. They are basically volunteers, and they're given a lot of responsibilities on screening a lot of diseases, including NCDs and some NTDs as well. So I'm just connecting the dots between the previous questions as well, like how teledermatology can be a big tool in reducing their burden of another course, another list of diseases to remember while screening by having the apps on their phone or having the phone supplied by the program. And that also connects to the thoughts of Inigo during his presentation, which he said that when we target national programs, we are somehow missing the connection between what is going on at the districts. And when we talk about skin NTDs and NTDs as a whole, the barriers are already there. They are usually common in children. They are usually common in those who have less access to services. And just trying to gather all the thoughts together, but basically all these questions that we are talking, all these points that we are discussing here, they all lead to getting trained human resources in a way where they are not burdened by using maybe volunteers, teledermatology, traditional healers, using them as access in order to break the barriers to equitable health services. Thank you.
Thanks very much, Priya.
Looking at this question, my question is, if you're unable to detect the disease, how do you provide the treatment? So we need to look at how to improve the workforce to be able to detect and then manage. But we have our national health insurance that covers some of these diseases. But the person who will diagnose this for it to be reimbursed, it's a challenge. Because if you don't write, maybe somebody has KB, somebody has this, health insurance will not cover it. So we need to also add how can we improve the workforce to be able to diagnose and then manage. Otherwise, the quality treatment will be there. So I don't know whether we can have guidelines that we can use to train community health workers to be able to detect, and then we bring in the digital technology for it to be referred to the few dermatologists in country and manage. So it should be a continuum sort of training community health worker, taking pictures to the dermatologists and looking at engaging the pharma companies to look at how they can also make the medication accessible and affordable, and by engaging, ministries and other things. So I think we should have that kind of circle completed to make this question more relevant. Thank you very much.
Thank you. So that's a really nice circle back to how important the diagnosis and the data is before you even start deciding how you're going to get access to treatment, but having both. Until we have point of care testing for all of our dermatological disorders, we won't hold our breath on some of that. Yeah.
Okay, maybe just a very brief attempt to help us move towards some tangible results, because I've been listening very carefully. This is an interesting discussion that I would like to have maybe in a 3-day to 5-day workshop, just to bring it out. But number one, in everything you do, if you want to make progress in this area, number one, ensure that you make the processes government-led. So that even if you have associations and partners and everything, put the government at the center. So mainstream it into some government program. That is how it will start gaining traction. The data that you collect, if you want to have good government ownership, I've now started understanding why we were not making headway with the NTDs. And you talked about it. Get health economists, quantify it in economic language. So that when you say, we are losing a certain amount of money every year because of these skin NTDs, the policymakers will sit up and they'll start listening. Or, people are spending this amount of money every year. That will help you to capture government ownership. Number two, what is our focus? Do we want to address the problem so that we probably eliminate these skin diseases or bring them down? Or do we just want to mobilize money, a lot of money, so that we continue generating income for stakeholders? We have to be very clear on that one. Otherwise, if we are not clear, then we are going to lose traction. And from the outset, I would advise, if we want to make headway, the focus should be on eliminating the problem. So even if we are mobilizing resources, let there be a very clear link to how eventually we are going to have a reduction in the disease burden. We have seen situations where a lot of good presentations are being made, but it gets lost at some point where now we have mobilized resources and we are having implementing partners and other people coming in, but the diseases are not going down. So if we can be able to do that, then it really helps us a lot. Then the third thing is how do we now ensure that we are conducting advocacy? I really want to underscore that. Advocacy that enables us to mobilize the community to come and take up these interventions, so that we can now be able to pick out, leverage the primary healthcare networks to pick out the data and show an increase. Because I'm very sure right now, you talked of a third of the population. I'm very sure we are nowhere near that. So that we can start showcasing how are we moving towards being able to capture that 1/3. I just really want to put that out so that we can be able to see how to focus on those three main areas. Thank you.
I just think you've done the most fantastic wrap-up, don't you think? So thank you so much for that fantastic wrap-up, for that call to action. And I really do think that we've captured some of the thoughts on here. I think we've got a priority around data acquisition and diagnosis, and your other three key points that we will take away. I had asked Liz to summarize, but I think we're now running out of time, so I think we should draw it to a close. We can stay and discuss over coffee and cake, I think. Cake. So more food and a photo. Yes, thank you. So if those of you are prepared to be involved in a photo, that would be just lovely. And thank you so much for your participation. Hope you enjoyed lunch. Thank you to everyone who organised it. And we look forward to some concrete actions and a resolution. Yes, thank you.